All right, if you're prepping for your specialty boards, you know that the vasculitis can be a real headache. While today, we're going to tackle one of the big ones, EGPA, which you might also know as Churg Strauss Syndrome. We're going to break down everything you need to know, all the high-yield stuff, and a big shout-out to Dr. Mohammed El-Najagi Mohammed for this fantastic content.
So let's jump right in. Picture this. You've got a patient with asthma that showed up in adulthood, they've got chronic sinus problems, and now all of a sudden they have new nerve pain, maybe a foot drop. Seems like a random mix of problems, right? Well, what if I told you they're all screaming one specific diagnosis?
And that diagnosis is eosinophilic granulomatosis with polyangiitis. Yeah, it's a mouthful, but the name actually gives us a ton of clues. The most important thing to remember is that it's a type of vasculitis, so inflammation of the blood vessels, and it specifically hits the small to medium ones. And it's often tied to something called ANCA.
Okay, for your exams, it's all about pattern recognition. So let's really dig into the classic clinical picture of EGPA. What are the clues in a question that should make a little light bulb go off in your head?
So what is that classic setup? What's the pattern that you absolutely positively cannot afford to miss on test day? It really all boils down to this classic triad. Number 1, asthma, especially asthma that starts when someone's an adult. Number 2, paranasal sinusitis, that chronic stuffy nose and sinus pressure that just won't quit. And number 3, the real kicker, mononeuritis multiplex. That's just a fancy way of saying nerve damage that pops up in different places, like causing a wrist drop or a foot drop. You see that combination? That's pure gold for an exam question. Okay, so you've got your clinical suspicion. Now you need the lab work to back it up. Let's get into the key numbers that you just have to have memorized. Now this is the big one. The E in EGPA stands for eosinophilic, and this is why. You're looking for a massive number of eosinophils in the blood, specifically more than 10% of the total white count. If you only remember one lab value from all of this, please make it this one.
Now let's talk serology. EGPA is what we call a panca-associated vasculitis. But here's the trap, and it's a classic one. It's only positive in about 60% of patients. You know what that means? A full 40% of people with the disease will be panca negative. So please, don't rule it out just because the test is negative. And what about the kidneys? With a lot of these vasculitis, we're always worried about the kidneys getting hit hard. But with EGPA, it's actually less common. Significant renal involvement only happens in about 20% of cases. And that's a really important clue that helps you distinguish it from other conditions.
Speaking of distinguishing it, let's tackle one of the most common mix-ups on exams, telling EGPA apart from its cousin, GPA, which you might remember as Wegener's. This really gets to the heart of it. Look, both conditions can give you sinus problems, but EGPA is defined by those allergic-type features. The second you see significant eosinophilia and a history of asthma, bam, your brain should go straight to EGPA. That's really the key thing that separates them. All right, before we wrap up, I've got one more high-yield clinical pearl for you. This is the kind of detail that could be the difference maker on a tricky question, and it has to do with a very common medication.
So let's think about this for a second. We've got a disease that's tied at the hip with asthma. So doesn't it make sense that a common asthma medication might play a role here? So what class of drug has been linked to unmasking or even precipitating EGPA?
And the answer is leukotriene receptor antagonists. Think montelukast. Now, the theory isn't really that the drug causes the disease. It's more that these meds are so good, they let you lower the dose of steroids. And when you do that, you might unmask an underlying EGPA that the steroids were keeping quiet. It's a classic association to have in your back pocket.
Okay, let's put it all together. To make sure this stuff is locked and loaded for exam day, we're going to finish with a super simple, actionable checklist. Here it is, your 3-step checklist. It's this simple. Step 1, you see a patient with adult-onset asthma, you have to suspect EGPA. Step 2, you look for that hallmark eosinophilia, that crazy high number over 10%. And step 3, you confirm it with signs of vasculitis, like that foot drop. Just remember, asthma, eosinophils, vasculitis. That's it. That's your ticket.
And that's really EGPA in a nutshell. The key, as always, is just recognizing the pattern. So the next time you get a board question about a patient with bad asthma and some new nerve pain, you're going to know exactly what you're looking for. You are going to spot the vasculitis. You've got this.